Welcome to this series of interviews with the giants of thoracic surgery. My name's Joel Dunning and I'm absolutely delighted to be here with Professor Joel Cooper. Joel, thank you very much for coming to talk to me.
You're very welcome, it's my pleasure.
You are the Emeritus Professor of Surgery at the University of Pennsylvania, the 84th President for the American Association for Thoracic Surgery. You graduated from Harvard Medical School in 1964 and underwent your surgical internship, residency and fellowship at the Massachusetts General Hospital with Hermes Griot, where you started your career. And amazingly, when you started your career then, you invented the low-pressure tracheal cuff at that time. You spent a year in the United Kingdom with Ronald Belsey and also John West, the famous respiratory physiologist. After your training, you were appointed to the faculty here in Toronto by Griff Pearson in 1972 and became head of division in 1978. And it was here where you led the team that was the first in the world to do a single lung transplant in 1983, a double lung transplant in 1986, and the first double lung transplant for cystic fibrosis in 1988. This would normally be enough for one person, but you've also led and been a leading light in lung volume reduction surgery, and you've even done some minimally invasive surgery with transcervical thymectomy. So thank you very much for coming to talk to me today. Before we talk about all your amazing developments in transplantation, I just wonder if you could start by telling us how you got into being surgery. What inspired you to become a surgeon?
I'm not really certain. I will tell you that I always like to do things with my hand. My mother said it was always because we went on fishing trips and I was always taking out the beating heart of the cleaning the fish and putting it into some salt water and watching it beat. I had an appendectomy, which I still remember when I was 3 years old. Apparently I was very ill at the time. Perhaps that had some influence, but I wanted to be a doctor. I wanted to be a surgeon. I think it was because I like to fix things and do things with my hand. And also, I think there was some incentive to do something of service to others. My dad was an Orthodox rabbi. I did not have the devotion to a calling such as that. To be a minister, to be rabbi, you are very, very much devoted in the service of others. It's amazing how many surgeons, if you ask, have ministers as fathers or grandfathers. So I think there's something in it to be of service to others, but not willing to make the sacrifices that some did. At any rate, so I was interested in doing things with my hand. I was interested in medicine. I didn't know what type of surgeon. I somehow imagined that I would be a neurosurgeon.
So obviously you did so much groundbreaking development of lung transplantation, but I wonder if you could take us back to that era just before the first successful one. What had been happening in the world in trying to develop it? What was it like before you achieved that first successful one?
Well, you know, the history of organ transplantation is interesting. Alexis Carrel, who got the Nobel Prize in 1912 for anastomosis of blood vessels, and he and the surgeon Guthrie in the 1907 to 1915 era were taking heart, lungs and attaching them to the neck of a cat, kidneys, hearts for short-term function. The first successful organ transplant was the kidney one by Dr. Joe Murray. He got the Nobel Prize for that, between identical twins. That was 1954. It was in 1960s that Tom Starzl finally succeeded after years of trying to do successful liver transplants. And the heart transplant between, I guess it was Shumway and Barnard, was in the 67, 68 region. And lungs took longer.
I believe there were 44 attempts worldwide. I mean, can you maybe tell us something of those attempts and what was it that they weren't getting right?
Yes, that is a very interesting story, and why the lung took so long. The lung is a very different organ. Dr. Hardy, James Hardy, in Mississippi in 1963 did the first attempt at a human lung transplant, single lung transplant. The recipient died of multi-system failure about 18 days later. It caused a lot of excitement in the thoracic surgical community. Thereafter, a number of attempts were made. In fact, between 1963 and 1978, there were 38 attempts. Only one person left hospital. All the others died in hospital. And the one who left hospital really didn't have much palliation from it. And so it was very discouraging. And by 1973, there had been about 32, 33 attempts. And between 73 and 83 in the world, there were maybe 5 attempts.
And you really went back to the lab to try and work out what is it that they were getting wrong. Could you tell me something of what you discovered?
Yes. In 1978, my colleague, Dr. Bill Nellums, who had been sent to work in Europe on lung transplant, Griff Pearson was one of many thoracic surgeons interested in it and doing experimental work. And Bill came back and organized a lung transplant for a person who was ventilator dependent, a young man who had been in a house fire. The operation was successful. The patient was able to go outside, get some fresh air off a ventilator in about 10 days. Died almost 3 weeks later. It was devastating. We then did an assessment. What had been going wrong? As we looked at all the cases that had been done, and by that time I think there were 38, only 6 or 7 lived more than 2 weeks. And every one of those died either of disruption of the airway anastomosis or in association with complications. So we decided, and I wasn't really involved in transplant then, Dr. Nellums moved out to the west coast of Canada, British Columbia, and there was no interest really in pursuing it further. The circumstances were Dr. Pearson came back from a trip to Europe. There was a young man from Brazil who wanted to get a PhD. He required that to be what's called a professor titulaire, I believe, in Brazil. If you want to be an academic professor, you have to have a PhD. He was interested in something to do with the airway. Griff Pearson said to me, would you take him into your lab? I was mostly working on extracorporeal perfusion and other things, not transplant. I said, let me think about it. A week later, I said to Griff, I'll tell you what. It's a big responsibility. Have him come. We'll put him to work on lung transplant. We recognized that the airway connection was an Achilles heel. I figured that'll keep him busy for a while. And he did, and spent 3 years there, and ultimately did get his PhD and returned to Brazil. So that's how I got into lung transplant.
And it was really the omental wrap that he discovered that you
Well,
forgot,
we
is that right?
decided we would conduct studies to look into why is the bronchial anastomosis failing. And I remember I had a good background in airway surgery from Dr. Grillo. I think it was Pasteur who said, in the field of experimental observation, chance favors the mind that's prepared. Sometimes it favors a mind which isn't prepared. That's called luck. And as luck would have it, when that patient in 1978, which Dr. Nellums conducted the single lung transplant at our institution, which was the first one done at Toronto General, when that patient died of bronchial disruption, I was part of the autopsy dissection. I was trained as a surgeon. If your patient dies, you do the autopsy. No one will be as interested as you. Now, I was not really a part of the surgical team. I was running the ECMO machine. But I'd done a lot of autopsies. I'd done some pathology in my training. We focused on the necrotic bronchus, which had come apart. But I still have a picture when I looked at the atrial anastomosis. Took away the lung. It was an atrium to atrium anastomosis that everyone had used to attach the veins. So I opened up the atrium, took a picture of the suture line, and if I showed you that picture, you would say, oh, that looks like it was done about 3 hours ago. There was no union of the anastomosis. There was not even a glossing over. The cleft between the two could be seen. There was no leakage. It was being held together by the sutures. There was absolutely, and this is 3 weeks later, there was no healing. It's a healing problem. Everyone thought it was a rejection problem. So we started off doing experiments to see what immunosuppression did. And so we took dogs, reimplanted the lung. So we disconnected the whole lung, therefore mimicking all the technical aspects, the cutting the bronchus, the cutting of the artery, the cutting of the atrium and the veins, the denervating of the lung, and then we attached it, which is actually in dogs much harder than a transplant in human. But Dr. Lima, the fellow from Brazil, was very good at it. And then half the dogs, we gave the same doses of immunosuppression, high-dose prednisone and azathioprine. They didn't need it, it was their own lung. And half the dogs, we didn't. And that's why you go to the laboratory, so you can control the situation. And sure enough, all the dogs who got the immunosuppression had the same constellation of bronchial disruption, ulceration of the donor bronchus, breakdown of the anastomosis, but not the ones who didn't get the immunosuppression. And we did a lot of work on wound healing and collagen, etc. We then tried just steroids or just azathioprine in the model. And as you would anticipate, and as we knew from tracheal surgery, not transplant surgery, steroids are not very good for airway healing. And so we had learned that the high doses of prednisone were probably responsible for a lot of the failures of those patients who survived 2 weeks or longer. Those who didn't survive 2 weeks were dying of infection and other problems relating to the fact that only the sickest patients on ventilators with multi-system failure were now being done because the score was 0 for 38, essentially. The airway anastomosis, however, in the dogs which didn't get the immunosuppression, although they healed primarily, there were about 50% stenosis. And we said, that's the ischemia. That's when we used the omentum, which I had also learned in my general surgical training was a wonderful organ for bringing in blood supply. You can bring it up on its vascular supply to the head, to the foot, if you lengthen the omentum. So we brought it up in our model, wrapped it around the bronchial anastomosis, did a series of injection studies on dogs a day later, 2 days later. We showed that within hours, literally, the omentum was attaching to the blood vessels on the ischemic side only, interestingly enough, very smart. It didn't initially form connections with the proximal bronchus. That was not ischemic. But with the donor bronchus, it revascularized it very quickly. So we then decided to use that as a blanket around it. We showed that you didn't get much stenosis. Maybe you got, instead of 50% narrowing, 10 to 20% narrowing, but they healed well. We did dogs with that, and the bronchus would heal. However, not when we gave prednisone. So there we were. We learned something, that it probably is not rejection. It is wound healing, and high doses steroids aren't very good. And then came luck again. Sandoz, cyclosporin. We got some. I'd heard about it from Stanford, where they had done successful heart-lung starting in 1981, Bruce Wrights and Norman Trimway. Sandoz gave us some for experimental. We ran it in our model. Wound healing was not adversely affected by either azathioprine or cyclosporin. So now we could use low doses of prednisone or none at all and put the prednisone in to the mix maybe 10 to 14 days later when you already had a healing wound. And then we could do transplants in dogs, omentum, cyclosporin, delayed prednisone, perfect healing, and we thought we were ready for humans.
So tell us how you took that amazing step from the dogs to that first human. Tom Hall, how did that come about, and when were you ready?
That was a good question, and the fact that I was in Canada, I think, made things much easier. I think if I'd been in the States, then all the regulatory things, it would have been a problem. All I had to do was propose to the hospital and get their approval to do it. So the next decision is, by that time I think there had been 44 in the world, and we had had one unsuccessful attempt before we had done this laboratory work, 2 in total, the one that Dr. Nellens did and one other one. Who are you going to transplant? If you are going to transplant someone who was on a ventilator, dying of respiratory failure, in hospital, in bed, you're not going to have success. Not at that stage, you weren't. So we wanted to choose a patient who did not have much of a life expectancy, either in time or in quality. So we chose idiopathic pulmonary fibrosis. And we said we will only do that. One of the failings of many of the early attempts was because many of them were in emphysema patients. And if you transplant a lung, particularly if you're having rejection or if you don't have good function of the lung, or good preservation of the lung, the compliance of the remaining lung allows the emphysema lung to get the ventilation, and not much goes to the new lung, which is stiffer than even a normal lung and very different than the emphysema lung. And then the emphysema lung would overinflate and push the heart over and crowd out the lung, making it even worse. We thought, we were wrong at the time, that we couldn't do single lungs for emphysema. Later on, that proved to be incorrect. So we said only pulmonary fibrosis. It's a very stiff lung. It's not going to steal the ventilation. The vascular resistance is increased, so it's not going to have a VQ mismatch, which was thought to be one of the sources of failure. And someone who has IPF, who has reached the stage of being oxygen dependent, who has an FEV1 under 1 liter, and who severely desaturates when just walking across this room, is a person, at least in those days, who would not be alive a year from now, probably would not be alive 6 months from now, and would have a miserable end. And so we felt that if we failed, we hadn't robbed the recipient of much good time. And one of the pulmonary physicians in the university who knew of our work had a patient. His name was Tom Hall. And he mentioned it to Tom Hall, and Tom came to see me. We also decided that we would only use a donor who was in the adjacent operating room. We didn't know anything about lung preservation. It was the heart solution, the preservation solution that people were then using. So we set up some very strict criteria. I said to the hospital, I would like you to give me permission to do 5 transplants. I'd like to set up a committee of disinterested individuals, ethicist, minister, pulmonary physician, and others, who will have to interview the recipient, or at least evaluate the recipient, to see that the recipient meets the criteria that we have established to do a patient in as successful opportunity as possible. And when we have done 5, we will not do any more until you've conducted a thorough review. And the hospital said, okay. It was very difficult, so Tom Hall came to see me. I said, Tom, you know there have been 44 attempts in the world and nobody has survived. He was a wonderful guy. He says, I'm grateful for the opportunity of being number 45. So, in November of 1983, on the 7th of November, a donor became available, a whole other story. We did the right single lung. He lived more than 5 years, good life, and that's how it started.
And amazingly, sort of after that, you actually had a really very high success rate after that.
Well, we did, because we chose very well. We had a team which was very good. We said we're not going to do any more transplants until this patient is a year out, so we could learn as much as possible. So we waited a year and did the next one, woman, with also IPF. We did it the next November, as it turns out. We used only a few nurses who we trained, only one anesthetist, and I was not popular because everyone wanted to have a go. But I felt we didn't have to go through a learning curve with everybody. Let's get ourselves trained up, and then we can train more people. And the second one was a success. I believe by the time we did 5, we had 4 of the 5 successful. And I think then so then we did one the first year, we did maybe two the second year, and maybe then we started doing a few more. And the first patient lived over 5 years, the second one lived 5 to 8 years. By then we also developed the double lung transplant, and we did that towards the end of 86. And some of those people lived, one of them just recently died at 27 years afterwards. Mm-hmm. So there wasn't much discussion after we had done the 5. We were successful enough, but we were very, very strict.
So you made a great success of the single lung transplantation. How did you evolve to being able to do double lung, and why did you decide on the sequential double lung transplant?
We decided to choose one disease at a time. Again, we were very strict. We chose idiopathic pulmonary fibrosis for the reasons that I said. Once we had some success, we wanted to do other patients, but every emphysema transplant that had been done had failed. It was a different era. It was thought the mismatch between a native lung and the transplant lung was a problem, so we wanted to be able to transplant both lungs. So we decided just to do one lung followed by the other with a transverse thoracosternotomy incision. So we put in one lung, then go to the other side of the table and put in the other one. And so we evolved from the en bloc double, and then we evolved to doing one side followed by the other, just 2 single lung trans, one following the other. And that then allowed us to progress and do cystic fibrosis patients, emphysema patients, pulmonary hypertension patients. But we took on each disease one at a time to decide when in the course of the disease we should do it, how should we manage them, what the post-op care would be like.
And so just to finish off, what do you think are the key difficulties in lung transplantation at the moment? I suppose there's a lot of things. There's ex vivo lung perfusion, there's the issues of donor availability. What do you think are the key issues for the next 10 years?
I think it's phenomenal what's happened. However, some things haven't changed. Yes, ex vivo is wonderful and will increase to some extent the donor pool, which will still be very short of what's needed. The biggest barrier to lung transplantation is available donors. The biggest barrier to long-term success is chronic rejection. Haven't made too much progress, but I am absolutely certain that induction of specific tolerance, the ability to make the person not reject the lung and be able to subsequently withdraw immunosuppression, will happen, as it happens sporadically with liver transplants. It's well known that some patients have had a liver transplant. You can withdraw all the immunosuppression if you need to, such as if you have a little lung nodule, which may be lymphoproliferative disease. And I've seen that, and they can go on for years and years and years and never reject the liver. You can certainly do it in mice and other things. So I am sure that induction of specific tolerance will ultimately come, and that will really change the long-term picture. What's going to change the availability of donors? Ex vivo and other things will help. Public information. On the other hand, as we have safer cars and helmets for motorcyclists, we may have a reducing donor pool. So what's going to come? Artificial lungs or xenotransplant? I think it was Norman Shumway who said xenotransplant is the future of organ transplant and always will be. So until I heard about the CRISPR, and I'm not a scientist, so I don't know a lot about it, where you can insert the human gene into a pig and things like that and avoid the hyperacute rejection of xenotransplant. Who knows? But maybe artificial lungs that you can implant will come along. But again, it's organ donation for the first problem, how many can be done, and it's going to be better anti-rejection, because every patient that I've had who've lived 15 years or more, and I have a number 20-some years out, have all had kidney transplants because of the nephrotoxicity of the drugs that are used. That'll get better.
Yeah, well, thank you very much for that amazing insight, truly inspirational. I just had one more little question. Your mother wrote a book at the age of 100 called Cooking at 100. What are you going to be doing when you're 100?
Yeah. Well, I do come from a long-lived family, and I'm sort of counting on that. Although I'm told that people with sort of type A personalities may be at greater risk. I don't know. I'll probably still be criticizing. I've made a career out of being a critic, but I've tried to be critical of my own work first and foremost. And I sort of learn from that process. I love to debate, and I'll take either side of a debate. And I learn by pushing hard and being pushed back and trying to learn. So I think I'll still be a critic if I'm around. As I say, even with transplant, I thought, well, what is success in transplant? What's it going to take to make someone say this is successful? And in my own mind, I thought, well, if we only get a year of good, that's not really success. We didn't even report, I think, our first transplant until 1986, the successful one in 83. I thought 2 years of good life might be, and I think that's fair. And I think it's always important you learn from challenging. So it never should be done in a personal way. But I think it's always good to recognize something which might be better, I think, in terms of innovation, not accepting it. Why do our post-operative patients in the old days get a fever? Well, that's the way things are. Then you start to learn some things about sepsis and urosepsis and other things. If you don't ask a question and you just assume that's the way things are, you're not going to make any progress. So I hope I'll still be critical.
Great. Well, for myself and everyone at CTSNet, I'd like to say thank you very much for a fantastic interview. Thank you very much.